Well then, ladies and gentlemen, we'll now be moving on to the third symposium on COPD. This will be chaired by Dr. Channa Ranasinghe and Dr. Chandana Kulathunga.
Good morning. So we'll begin the symposium on chronic obstructive pulmonary disease. And I think it's going to be very interesting. There'll be 4 lectures on various aspects of chronic obstructive pulmonary disease. So first, I would like to introduce the first lecturer, Dr. Vatsala Gunasinghe, consultant respiratory physician, National Hospital for Respiratory Disease, Valisara, Ragama. So she'll talk on vaping, a hidden monster.
Good morning to you all. First and foremost, I would like to thank Sri Lanka College of Pulmonologists to give me this opportunity to talk about this important topic today. So we will be discussing regarding vaping, a hidden monster. So what's vaping? When we like in the even professional gatherings, even social gatherings, when this topic comes, it seems like most of us are actually very fluid in our opinion. We are not sure. These are a few comments. What is vaping? Is it related to smoking? Or is it available in Sri Lanka? Is it really harmful? I have some friends who use them. Oh, I have tried it. It has many flavors. Really, are there any serious side effects? So these are the things that come up. So we are all not very sure about vaping and what is vaping. So this is Mr. Trump. He's also once commented on a vaping, that is, nobody knows too much about it. So that's it. So in my lecture, I'm going to go through certain things and facts about vaping. And so I hope you will be having a firm idea or firm knowledge after listening to this lecture, and you will have decided on vaping, not having like fluid thoughts or indecision. So lecture outline will be, we'll be discussing about what is vaping, how did it come to the market, and types of vaping, and the harms, and recent regulations, and what is the future for us, especially considering Sri Lanka. So what is vaping? It's also known as e-cigarettes, vape, e-hookahs, vape pens, so there are many names. But it basically means the same thing. So it's an electronic device that simulates tobacco smoking. And you can see in the picture, there's an atomizer, and there's a battery and also a cartridge containing a fluid which is called a vape fluid or vape juice, e-liquid. So there are different terms that you use, but basically this atomizer will make aerosols and or tiny droplets, and actually the person inhales the vapor. And it can be activated either by the puffs that is being taken or pressing a button. So some of these are also refillable, so that's a problem. So when you look at these types of e-cigarettes, mainly they are electronic nicotine delivery system. That means most of them will have nicotine, but there are what it calls ENNDS, that is electronic non-nicotine delivery systems as well. When you look at what is the constituent of the vape juice or the e-liquid, mostly it will have nicotine and actually these 4 main components. So nicotine and the either propylene glycol or vegetable glycerin base or a mixture of it, and flavorings. Actually there are over thousands of flavors. So this is a real problem. We'll discuss about these things, and also water. And also it has been, you can see the data, there had been like identified sometimes more than 100 chemicals. And some compounds are identifiable, some are even not identified. So these are problems. Then also we have, in the research, they have found tin, lead, nickel, chromium, manganese, and arsenic even in some of these fluids. So what are the problems? Nicotine, as you know, it's not a carcinogen, but it's an addictive substance that will cause psychological as well as physical addiction. And also it might prime the brain to become addicted to other substances as well. And these PGs and VGs, they are generally considered safe, but when they are like heated, we are not very sure. Sometimes they might form aldehydes, which might be having toxic effects. And flavorings, also some of the flavors, like diacetyl, sometimes they might cause, there is evidence that even of cases of obliterative bronchiolitis related to these substances. So how did the vaping come about? As you know, the community has used tobacco for so many years. There are so many products like pre-made commercial smoking products as well as handmade ones, and also sniffing and chewing. Then later on, these two types, you have to understand these two things are different. One is heated tobacco products. These are not e-cigarettes. These are tobacco products that are not heated. Not burn. There's no burn, but heating will release. But it will contain tobacco, the topmost one, and tobacco and similar side effects as tobacco use. Then there comes the vaping or vapes or e-cigarettes, which don't have tar or carbon monoxide as cigarettes or tobacco has, but there are still problems associated. So e-cigarettes actually entered the market as consumer products without much government regulations. And also it was initially, these were produced by small companies, but later on big tobacco companies have bought them and they are developing these e-cigarettes. Just a brief thing to pass to present, because when you talk about e-cigarettes, you have to know about smoking and cigarettes as well. So you will can realize the facts in the context of all this background information. So, you know, we have been using like cigarettes since 1500s, and there was popularization during World War, and sales for like introduced to females, and a lot of marketing. From 1700s we knew about the harms, but only in 1990s we actually started doing something about it. And although we taxed tobacco products fairly early, the regulations regarding the risk came much later. And so there are warning labels, and there's banning on ads and advertising. And there are graphic images. You know, in Sri Lanka also we have graphic images in the cigarette packets. And also there are bans on public smoking, as well as restriction on sales on younger children. So these has been the history of tobacco smoking. And also there's a ban on point of sale advertising as well. So even with all these, knowing the harms, we are still using tobacco. Why? Because marketing will motivate a person to start this habit or initiation, and also then the addictive properties of that components will lead to maintenance. You can see the effective marketing they have used for tobacco over the many years. Marketing for men, children, the young adults, females, men. So you can see. So tobacco, there's a fight between advertising and marketing strategies versus legislation. Is it successful? So there's a plateau in developed countries, but still it is killing more than 8 million people a year, and also there's a rise in developing world as well as females and youth of tobacco smoking. Now we are coming up with this these new challenges, those are the novel and emerging nicotine and tobacco products we talked about earlier. So when you look at e-cigarettes, there are few generations of them, and you can see the first generations look more like a cigarette, but later on they change. You can see they look like pen devices, and very small, very attractive, colorful. So actually, you can, like even in school settings, it's very easy to be disguised and taken to a school even. So we look at the vaping statistics. You can see these are international US data, but mind you, you can see there's a high use of among children, middle and high school students, middle school students, that is very young, isn't it? And also among current adult e-cigarette users, the percentage who has never smoked cigarette is highest among those aged 18 to 24 years. So that means more novel smokers using e-cigarettes, e-cigarette users in younger age groups like teens. So that's the problem. They have not smoked. They are not using the e-cigarette as a aid to stop smoking or come down on cigarettes, but they are starting a new habit. So generally, you know, e-cigarettes are generally marketed as a smoking cessation aid, but why the youth is using it? That is because the marketing strategies are targeting the youth. There's multidimensional influences. You can see there's a buzz in social media, and also they sponsor the music and festival events, and there are appealing flavors. I said more than 7,000 flavors are there. So you can see the pictures. These are more attractive to small children, isn't it? They are very young children. So these are not for adults. This is marketing for targeting the children. And you can even see a small bunny in one of the vape pens here. So, so that is targeting targeting the youth. And also sometimes they offer scholarships also. So there's a huge marketing going on. So is it harmful? Yes, harms are many. So at an individual level, if you look, there are risks due to the constituents. You know, nicotine exposure, aerosols, we don't know what we are inhaling and the long-term effects. And also risks due to the byproducts, and also this refilling. I said there are refillable cartridges. So there's this refill can be from unreliable sources and potential contamination. And also these are battery-operated devices, and so explosions, burns, chemical injuries, those are also reported. And also, as you know, vaping is identified as a risk factor for environmental COPD. In the Goal 2022 update, you can see it comes under smoking, exposure to tobacco smoke, cannabis, and also vaping and e-cigarettes is mentioned. So it's there is definite harm of using this vape. So most serious side effect noted is what is called e-valley, or e-cigarettes or vaping use associated lung injury. There was an outbreak in 2022 where it's like about 68 deaths, and but still cases are coming, and although infrequent, still this is happening. And when they analyze the data, it is mostly in people who have used vaping devices that they have modified their vaping devices, and or used black market modified e-liquids, also e-liquids containing the substance THC. Also they have related to vitamin E acetate that is used as a thickening agent as a potential source of this E-valley. So E-valley is a vaping product related lung disease, which is acute or subacute illness and can lead to severe or life-threatening disease. And as I said, there was an outbreak. And mind you, although they stated that this is related to contamination and all, there are cases that in patients who have already used nicotine-containing substances and also even without any illicit contamination and all. So these are the pictures of one case report. You can see a severe arch-like picture. It's a case of the 22-year-old Caucasian male who has used vape with THC or tetrahydrocannabinol and severe acute respiratory illness needing ICU care, but managed to recover. So if you look at the potential criteria for EVALI, to confirm a case, use of e-cigarettes within previous 90 days, lung opacities on chest X-ray or CT, and also exclusion of lung infection, and also absence of a plausible alternative diagnosis. So those are the general criteria for, those are the proposed criteria for EVALI diagnosis. So now more fatal cases were in over 35 years of age and history of asthma, cardiac disease, and also obese patients. So these are similar to other causes of acute respiratory distress. So treatment of EVALI, optimal treatment is not known, and you have to treat as a community-acquired pneumonia and exclude infection like COVID-19, and steroid therapy, antivirals, and supportive care. Still, there are continued concerns. You know, there are risk of long-term cardiovascular problems, and also we largely don't know what will happen if you inhale these types of substances long-term, and also risk related to the devices. And when you look at it in a public health point of view, there's a huge problem here. One is nicotine dependence. Use of e-cigarettes raises the risk of establishing nicotine dependence in novice users, and the other one is the normalizing smoking behavior. So these are two major issues. And there's sample evidence that e-cigarettes have been marketed using many of the strategies previously used by tobacco companies to market conventional cigarettes to youth. So it has been like stated and proven this is happening. So what does the CDC say? So what is the bottom line? E-cigarettes have the potential to benefit adults, smokers who are not pregnant, if used as a complete substitute for regular cigarettes and other smoked tobacco products. But it's not safe in youth, young adults, pregnant women, as well as adults who not currently use tobacco products. And while e-cigarettes have potential to benefit some people and cause harm to the others, scientists still have a lot to learn. So if you are never smoked, you should never use these vaping products as well. And we need additional research also. So what are the international control measures? So composition of vape juice is regulated in most of the Western countries, and actually speaking, FDA has never stated that e-cigarettes have been approved as a cessation device or authorized to do so. And also FDA, this is US data, they monitor the national usage rate for tobacco products, including annual youth surveys. And this is the last one is the most important. You saw these ads, very attractive ads from a company called Jules, targeting youth. So actually they have in 2022 June, FDA has issued marketing denial orders to Jules so that they have to withdraw all products, and they have been banned from advertising because their ads targeted the youth. And they think that this rise in the youth using vaping is related to this marketing. So what about Sri Lanka? Is it here? Yes, it is definitely here. If you talk with young, school children, teenagers, you will know that and young adults, they are using it. And it's very common practice in Sri Lanka, although it is not like we are not aware, parents are not aware, even the medical field is not that much aware, but it is there in the community. So what is the way forward? So we have to do review and research on current Sri Lankan market and the rate of use among youth, and we need clear legislation on availability outside a formal smoking cessation program, and also strict legislation on marketing availability to youth and novice. And also, more than anything else, we have to be aware, we should know what is vaping, and you should have a firm idea that this is harmful, especially for youth, and we should all act together to prevent this becoming more and more popular. And we know we are in a problematic era where the youth are using drugs like ice and all, so this is also coming into the same picture. We should be very vigilant. These are my references. Thank you very much. I would like to take my questions at the end if there's any. Thank you.
Thank you very much, Vatsala. An excellent lecture and perfectly stuck to time, relevant and timely. I'm sure that there'll be a lot of questions at the end. Our second lecture is from Dr. Sudeep Salvin, who is well known to our audience. He is Chairman and Director of Research and Training at his institute in Pune, and he will talk to us about the Gold Guidelines of 2023, a shift in thinking.
Thank you so much for those kind words of welcome and introduction. Wish you all a very good morning. I bring to you greetings from India. And at the outset, I would like to express my very sincere thanks to the Sri Lankan College of Pulmonologists for inviting me to this wonderful academic feast at this National Respiratory Conference. I'm going to be talking about the Gold 2023 report, which was released in November last year. And what are the new things that have come out in this new report? Although we popularly call this as the Gold Guidelines, it is very clear that the Gold Committee would not like these to be called as Gold Guidelines. They like to be called as a strategy report. So this is the Gold 2023 strategy report rather than guidelines, although it is popularly called as guidelines. The strategy report that the Global Initiative for Obstructive Lung Disease publishes every year started since 1997, and on the third Wednesday of every November, it releases the new report in the form of the new Gold Strategy Report. So this has been going on for quite some time now, for over 20 years. And the knowledge base that the Gold Strategy Report has been sharing with the whole world has been absolutely immense. So last year on the 16th of November, the new Gold Strategy Report of 2023 was released. Every year they have a theme for the COPD conference, or the World COPD Day. And this year it was Your Lungs for Life. The Gold Board of Directors are the ones who actually drive the entire program, and I've been very fortunate enough to be one of the members of this board. But the real hard work for developing the scientific content goes to the scientific committee of Gold. And I've put the pictures of all these key opinion leaders from the different parts of the world who have worked very, very hard to bring about this new Gold Strategy Report. So what is new in the Gold 2023 Strategy Report? First and foremost, the definition of COPD seems to have gone some change. Compared to last year, there are two things that are distinctly missing from the 2023 definition of COPD. One is that COPD is a common, preventable, and treatable disease. And I'll tell you why, because this has got a special mention later on after the definition. And the second point is that it is usually caused by significant exposure to noxious particles or gases has been removed. And for a very good reason. because now we have understood that COPD can be caused by a whole host of different non-smoking risk factors as well. So to bring that into the limelight, they have removed this from the definition. Within the definition, they have added a couple of words which I think are very important. The first one is the fact that COPD is a heterogeneous lung condition. It is not a single disease. It's a variety of different diseases that can present as a COPD. And then the other new words are dyspnea, sputum production, and exacerbations, which have been given a little bit of importance. And bronchitis and emphysema have been added again, which were there in the earlier definitions. Now, after the definition, they talk about new opportunities for COPD. And within that, here they do mention that COPD is a common preventable and treatable disease. But the challenge is that a large number of these COPD patients remain undiagnosed or wrongly diagnosed. And this causes more suffering and death associated with COPD. And therefore, it is crucial that we pick up these COPD cases from the community early, we diagnose them correctly, and then we treat them appropriately. So there's a special mention about this after the definition. The second component of the new opportunities is the realization that non-smoking risk factors are equally important. And two new terms have been added, which were there in the last year's Gold Strategy report, but this year they've got a bigger emphasis. And that is pre-COPD and PRISM. What these two terms are, I'll elaborate that in the subsequent slides. The importance of early diagnosis has been given a lot of importance. And you can see this a report on COPD published in the Lancet, the 5th of September, talks about the need for early diagnosis. And this is a wonderful graph that depicts that. So you can see that on the x-axis is age. The brown colored image tells us about the declining lung function that happens once the disease sets in. The symptoms start appearing a little later on, after the lung function starts declining, and the diagnosis happens at a much later stage. And it is at this point of time that we make a diagnosis and we treat them, when in fact we have lost this entire time period where we could have done something important for the patient. So here is the new scenario. The lung function may start declining early, but the moment the symptoms start, that is the time when you should start making the diagnosis, not few months or few years after the symptoms have started. So for that, we need to ensure that there is a good national COPD screening program. And they have emphasized a lot on this, that every country should ensure that there's a screening program for COPD. Now, those patients who have no symptoms, but have been exposed to risk factors such as tobacco smoke or other risk factors associated with COPD, maybe it is not a good idea to do screening in these patients because this would not be cost effective. However, if you have individuals who have symptoms suggestive of COPD and have been exposed to risk factors, please screen for them. You can use different types of novel screening tools. There are so many of them that have been developed in the last few years, be it a questionnaire with or without a peak flow meter as screening tools, and then spirometry, obviously, to confirm the diagnosis of COPD. So there's a lot of emphasis that has been given on COPD screening as a necessity. Then there are these two terms that have been given a lot of importance. One is pre-COPD. And the reason behind that is there are a significant number of people who present with respiratory symptoms who have been exposed to risk factors and they have a normal spirometry. So by definition, you just cannot label them to have COPD because there is no obstruction. There's no obstruction to the airflow. So by definition, you cannot call them a COPD. But when you do an HRCT or when you do a body box plethysmography or if you do a lung diffusion test, you will find that there are physiological changes and radiological changes that have already set in, despite the fact that spirometry is normal. So then now you should label them as cases of pre-COPD. Important to realize that pre-COPD can occur at any age. Gone is the time when COPD was believed to be a disease that starts after the age of 40. Now you can have COPD at a much younger age group of even 25 to 30 years. Do they suggest that they should be treated? Yes, they think that it should be treated by appropriate drugs. And however, there are no good randomized controlled trials to give us that advice. The second that they have emphasized a lot is called PRISM. PRISM stands for Preserved Ratio Impaired Spirometry. The preserved ratio is for the FEV1 upon FVC ratio, which is normal, but the FVC value is less than 80% predicted, or the FEV1 value is less than 80% predicted. Earlier, we would call this as suggestive of restrictive lung disease. But now there's a new term. Instead of restrictive lung disease, we should call them as PRISM. Now, PRISM is widely seen in the community, seen in former smokers, among those especially who have low body mass index. And what is interesting is the fact that if you follow these patients who have PRISM today over a period of 5 years, half of them will end up developing frank COPD. So this is PRISM obviously represents an early type of COPD or pre-COPD. So pre-COPD and PRISM have been given a lot of importance in the 2023 report. The next big thing that has happened in the 2023 report is the classification of COPD based on the etiotypes, the causes of COPD. You know, all these years, COPD was thought to be primarily caused by tobacco smoking. Now, this Gold 2023 report talks about 7 different categories of COPD. They're called as COPD-G, COPD-D, COPD-C, P, I, A, U. Now, what are these? COPD-G stands for genetically determined COPD. For example, alpha-1 antitrypsin deficiency. That's a genetic cause of COPD. So that's COPD genetic cause. COPD-D is because of abnormal lung development that happens during childhood or during in vitro, when the child is in the mother's womb. So COPD, because of that, should be labeled as COPD-D. Then environmental COPD. So cigarette smoking COPD is called COPD-C. COPD-P is because of pollution, be it indoor air pollution or be it outdoor air pollution. COPD-I is because of infections. So post-TB lung disease is now known to be a common risk factor for COPD. Or recurrent respiratory tract infections during childhood is also a risk factor for COPD called as COPD-I. COPD-A is poorly treated asthma that now starts manifesting with features suggestive of COPD. So previous asthma, poorly treated asthma, badly treated asthma, now showing COPD features should be labeled as COPD-A. And then COPD-U is of unknown cause. So look at how the etiotype of COPD has dramatically changed in 2023. There's a lot of mention about the role of high-resolution CT scan in COPD patients for various reasons. One is high-resolution CT scan can pick up COPD even when spirometry is normal. So it can help you in early diagnosis. It can help you in differential diagnosis. And especially if you're thinking of lung volume reduction surgery, then high-resolution CT scan becomes a necessity. There is a special mention about regular screening for lung cancer in patients with COPD. And especially if a patient who is above the age of 50 has more than 20 pack years of smoking, the recommendation is that they should undergo every 6 months or every year HRCT screening to look for presence of underlying lung cancer. Then something big that has happened in COPD with the 2023 report. Until last year, the classification of COPD assessment was based on A, B, C, D. So A, B, the ones that represent the symptoms, and C and D are the ones that represent the number of exacerbations. So depending on the symptoms as assessed by MMRC or the CAT score, you would categorize them into A or B. And then depending on the number of exacerbations, you would categorize them into C or D. Now, this has been changed. So instead of A, B, C, D, we now have A, B, and E classification. So the C has been dropped and the D has been replaced with E, which represents exacerbation. So anybody who has had more than or equal to 2 moderate exacerbations or more or equal to 1 exacerbation leading to hospitalization should be categorized as E, irrespective of what the symptoms were. So a lot of emphasis and importance given to exacerbation as an important determinant of what should be the appropriate pharmacotherapy. So this is a big change that has happened. A, B, C, D replaced with A, B, E. Now, to determine whether it should be, how to categorize them into A or B, you have the MMRC and you have the CAT scores. So they very strongly recommend that every clinician who is seeing patients of COPD must have these pre-printed ones given to the patient when the patient is sitting in the waiting area. So if the patient primarily comes with complaints of shortness of breath, use the MMRC's grading. If it's not shortness of breath, then use the CAT assessment. And then you get a score for these, and then use those scores to classify them into A or B. And for E, I already told you what is the criteria for calling it as E. The initial pharmacological treatment has also changed dramatically. So what is the new thing over here? The new thing over here is there is a strong recommendation of not to use a combination of ICS plus LABA. What drugs are allowed? Bronchodilator, whether it is a short-acting bronchodilator or a long-acting bronchodilator, a beta agonist or an anticholinergic, anything can be used if the COPD category is A. If the category is B, then you have to use a LABA and a LAMA combination. That is the recommendation. If it is group E, the base treatment is always LABA plus LAMA, and wherever required, you then replace that with a triple drug combination of ICS, LABA, LAMA. There is no place for ICS plus LABA in the new Gold 2023 strategy report. So simplifying things, a bronchodilator. The next step is dual bronchodilators, which are long-acting, and they have to have an beta agonist and an anticholinergic, and then go to the triple drug combination. So ICS plus LABA, as I said, has been removed. Now, which are the conditions where you should consider giving them triple drug combination, which is adding ICS to LABA plus LAMA? So those who have history of hospitalization for exacerbations, well, you should then start putting them on a triple drug combination. Or if they've had more than or equal to 2 moderate exacerbations, or if the blood eosinophil count is more than 300 cells per microliter, or there is a history of concomitant asthma, previous history of asthma, concomitant asthma, you obviously need to give them inhaled corticosteroids, but not ICS plus LABA, you give ICS plus LABA plus LAMA. There are 2 conditions where you may consider giving them, especially if there's only 1 moderate exacerbation in the last 1 year and the blood eosinophil counts are between 100 to 300. Take a clinical judgment and then take a call. However, if the patient has complained of repeated pneumonia events in the past, most certainly don't give them inhaled corticosteroids. Or if the blood eosinophil count is less than 100, don't give them inhaled corticosteroids. Or if there's a history of mycobacterial infarction, don't give them inhaled corticosteroids. So very clear guidelines as to when inhaled corticosteroids should be added. Now, this is the base treatment. Now, when the patient comes for a follow-up, what are the things that you should look for? So in the box on the top, they give a lot of importance for this. Check whether the adherence, inhaler technique, and are correct. Check whether the patient has any coexisting multimorbidities which need to be treated. Consider predominant treatable traits, so especially if it's breathlessness, then what should be the guidelines, and what if it is exacerbations, then what should be the guidelines, which are mentioned below. And then assess the response, adjust the treatment, and then review with follow-up. So if your patient comes for a follow-up with predominantly breathlessness is the main symptom, the focus of the treatment should only be on bronchodilators, long-acting bronchodilators. Don't give them inhaled corticosteroids. ICS is not a good drug to be given to patients who have come with a follow-up with predominant symptoms of breathlessness. If the ICS LABA is not working, then you may consider switching the inhaler device, or or investigate other causes of breathlessness, such as congestive heart failure is a very common comorbid condition that is associated with that. If the patient has predominant exacerbations, then think of giving inhaled corticosteroid as an add-on drug to the LABA plus LAMA. You may consider giving roflumilast if the patient has symptoms of chronic bronchitis or the FEV1 is less than 50%, and consider giving azithromycin if it's a former smoker because of recurrent lower respiratory tract infection. So that's the standard pharmacotherapy of COPD. Then the realization that you could reduce mortality in COPD, which was until very recently, ascribed only to long-term oxygen therapy, is the only treatment that can reduce mortality in COPD. But now, so many treatments can reduce mortality. Especially the use of triple drug combination is in the recent past has been shown to reduce mortality in COPD, and that's a very good sign because no pharmacotherapy was shown to reduce mortality earlier, but now there is good evidence to show that use of ICS plus LAMA can reduce COPD mortality to a significant amount. Like asthma, the GINA guidelines have been focusing a lot on choosing the right inhaler device, ensuring that the adherence is proper, and so on. There's a big portion of the GINA 2023 report that talks about choice of inhaler device. Remember that a lot of these long-acting bronchodilators are available in a dry powder form. And many patients of COPD may not necessarily be able to generate the inspiratory flows to use the dry powder inhaler devices correctly. So there's a caution mentioned over here. Wherever possible, prefer to use an MDI with a spacer and so on. But a lot of emphasis on ensuring that the technique of using the inhaler is correct and the adherence is also proper. The non-pharmacological treatment has also got a lot of importance, and especially self-management educational programs like what we used to normally do for asthma, maintenance of exercise program and physical activity, adequate sleep and a healthy diet. But more important than all this is the right-hand side of this slide that tells you which vaccines patients of COPD must be given. 5 vaccines that all patients of COPD must receive. Influenza vaccine, pneumococcal vaccine, COVID-19 vaccine, the pertussis or the diphtheria pertussis tetanus vaccine, the herpes, the shingles vaccine. 5 vaccines should be given to all patients of COPD. There's a lot of emphasis on that. Pulmonary rehabilitation is also, there's a big section on pulmonary rehabilitation. So here are the interventions that reduce COPD mortality. And you can see that pharmacotherapy for the first time is now established as a treatment that reduces COPD mortality, which was not there before. And in the non-pharmacological treatment, it was only LTOT. Now smoking cessation, pulmonary rehabilitation, non-invasive positive pressure ventilation, lung volume reduction surgeries have all been shown to reduce COPD mortality. Exciting times for COPD, where now we have good scientific evidence that we can reduce them from dying. There's a very new proposal about the classification of the acute exacerbation of COPD. Until recently, we were classifying acute exacerbation of COPD into mild, moderate, and severe. And that was largely based on the type of treatment that was required to treat it. So if the patient required only a SABA treatment, then we called it as mild exacerbation. If the patient required SABA plus antibiotics or an oral corticosteroid, we called it moderate. And if the patient required hospitalization, we called it severe. But this classification was retrospective after the treatment that the patient received. The Rome proposal was published in the American Journal of Respiratory Critical Care Medicine last year, and that is now included in the GOLD 2023 report, giving you very specific objective criteria to label the acute exacerbation of COPD as mild, moderate, or severe. And for this, various parameters are used, such as the breathlessness, the visual acuity scale, then the respiratory rate, the heart rate, the resting oxygen saturation, the CRP levels, and so on. So based on all these parameters, you should objectively categorize them into mild, moderate, or severe, and then you treat them accordingly. One of the other new things that has happened in the 2023 report is this very, very big section on surgical and other interventional therapies in patients with COPD, especially those with emphysema. So there's a lot of mention about bulectomies, a lot of mention about endoscopic lung volume reduction surgery, mention about endobronchial valves, lung volume reduction coils, and lung volume reduction surgeries. So I think these are exciting times for surgeons and to use this as an added form of treatment. And they also talk about the importance of. You will find that there are physiological changes and radiological changes that have already set in, despite the fact that spirometry is normal. So then now you should label them as cases of pre-COPD. It's important to realize that pre-COPD can occur at any age. Gone is the time when COPD was believed to be a disease that starts after the age of 40. Now you can have COPD at a much younger age group of even 25 to 30 years. Do they suggest that they should be treated? Yes, they think that it should be treated by appropriate drugs. And however, there are no good randomized controlled trials to give us that advice. The second that they have emphasized a lot is called PRISM. PRISM stands for Preserved Ratio Impaired Spirometry. The preserved ratio is for the FeV1 upon FVC ratio, which is normal, but the FVC value is less than 80% predicted, or the FeV1 value is less than 80% predicted. Earlier, we would call this as suggestive of restrictive lung disease. But now there's a new term. Instead of restrictive lung disease, we should call them as PRISM. Now, PRISM is widely seen in the community, seen in former smokers, among those especially who have low body mass index. And what is interesting is the fact that if you follow these patients who have PRISM today over a period of 5 years, half of them will end up developing frank COPD. So this is PRISM obviously represents an early type of COPD or pre-COPD. So pre-COPD and PRISM have been given a lot of importance in the 2023 report. The next big thing that has happened in the 2023 report is the classification of COPD based on the etiotypes, the causes of COPD. You know, all these years, COPD was thought to be primarily caused by tobacco smoking. Now, this Gold 2023 report talks about 7 different categories of COPD. They're called as COPD-G, COPD-D, COPD-C, P, I, A, U. Now, what are these? COPD-G stands for genetically determined COPD. For example, alpha-1 antitrypsin deficiency. That's a genetic cause of COPD. So that's COPD genetic cause. COPD-D is because of abnormal lung development that happens during childhood or during in vitro, when the child is in the mother's womb. So COPD, because of that, should be labeled as COPD-D. Then environmental COPD. So cigarette smoking COPD is called COPD-C. COPD-P is because of pollution, be it indoor air pollution or be it outdoor air pollution. COPD-I is because of infections. So post-TB lung disease is now known to be a common risk factor for COPD. Or recurrent respiratory tract infections during childhood is also a risk factor for COPD called as COPD-I. COPD-A is poorly treated asthma that now starts manifesting with features suggestive of COPD. So previous asthma, poorly treated asthma, badly treated asthma, now showing COPD features should be labeled as COPD-A. And then COPD-U is of unknown cause. So look at how the etiotype of COPD has dramatically changed in 2023. There's a lot of mention about the role of high-resolution CT scan in COPD patients for various reasons. One is high-resolution CT scan can pick up COPD even when spirometry is normal. So it can help you in early diagnosis. It can help you in differential diagnosis. And especially if you're thinking of lung volume reduction surgery, then high-resolution CT scan becomes a necessity. There is a special mention about regular screening for lung cancer in patients with COPD. And especially if a patient who is above the age of 50 has more than 20 pack years of smoking, the recommendation is that they should undergo every 6 months or every year HRCT screening to look for presence of underlying lung cancer. Then something big that has happened in COPD with the 2023 report. Until last year, the classification of COPD assessment was based on A, B, C, D. So A, B, the ones that represent the symptoms, and C and D are the ones that represent the number of exacerbations. So depending on the symptoms as assessed by MMRC or the CAT score, you would categorize them into A or B. And then depending on the number of exacerbations, you would categorize them into C or D. Now this has been changed. So instead of A, B, C, D, we now have A, B, and E classification. So the C has been dropped and the D has been replaced with E, which represents exacerbation. So anybody who has had more than or equal to 2 moderate exacerbations or more or equal to 1 exacerbation leading to hospitalization should be categorized as E, irrespective of what the symptoms were. So a lot of emphasis and importance given to exacerbation as an important determinant of what should be the appropriate pharmacotherapy. So this is a big change that has happened. A, B, C, D replaced with A, B, E. Now, to determine whether it should be, how to categorize them into A or B, you have the MMRC and you have the CAT scores. So they very strongly recommend that every clinician who is seeing patients of COPD must have these pre-printed ones given to the patient when the patient is sitting in the waiting area. So if the patient primarily comes with complaints of shortness of breath, use the MMRC's grading. If it's not shortness of breath, then use the CAT assessment. And then you get a score for these, and then use those scores to classify them into A or B. And for E, I already told you what is the criteria for calling it as E. The initial pharmacological treatment has also changed dramatically. So what is the new thing over here? The new thing over here is there is a strong recommendation of not to use a combination of ICS plus LABA. What drugs are allowed? Bronchodilator, whether it is a short-acting bronchodilator or a long-acting bronchodilator, a beta agonist or an anticholinergic, anything can be used if the COPD category is A. If the category is B, then you have to use a LABA and a LAMA combination. That is the recommendation. If it is group E, the base treatment is always LABA plus LAMA, and wherever required, you then replace that with with a triple drug combination of ICS, LABA, LAMA. There is no place for ICS plus LABA in the new Goal 2023 strategy report. So simplifying things, a bronchodilator. The next step is dual bronchodilators, which are long acting, and they have to have an beta agonist and an anticholinergic, and then go to the triple drug combination. So ICS plus LABA, as I said, has been removed. Now, which are the conditions where you should consider giving them triple drug combination, which is adding ICS to LABA plus LAMA? So those who have history of hospitalization for exacerbations, well, you should then start putting them on a triple drug combination. Or if they've had more than or equal to 2 moderate exacerbations, or if the blood eosinophil count is more than 300 cells per microliter, or there is a history of concomitant asthma, previous history of asthma, concomitant asthma, you obviously need to give them inhaled corticosteroids, but not ICS plus LABA, you give ICS plus LABA plus LAMA. There are 2 conditions where you may consider giving them, especially if there's only 1 moderate exacerbation in the last 1 year and the blood eosinophil counts are between 100 to 300. Take a clinical judgment and then take a call. However, if the patient has complained of repeated pneumonia events in the past, most certainly don't give them inhaled corticosteroids. Or if the blood eosinophil count is less than 100, don't give them inhaled corticosteroids. Or if there's a history of mycobacterial infarction, don't give them inhaled corticosteroids. So very clear guidelines as to when inhaled corticosteroids should be added. Now, this is the base treatment. Now, when the patient comes for a follow-up, what are the things that you should look for? So in the box on the top, they give a lot of importance for this. Check whether the adherence, inhaler technique, and are correct. Check whether the patient has any coexisting multimorbidities which need to be treated. Consider predominant treatable traits, so especially if it's breathlessness, then what should be the guidelines, and what if it is exacerbations, then what should be the guidelines, which are mentioned below. And then assess the response, adjust the treatment, and then review with follow-up. So if a patient comes for a follow-up with predominantly breathlessness, breathlessness is the main symptom. The focus of the treatment should only be on bronchodilators, long-acting bronchodilators. Don't give them inhaled corticosteroids. ICS is not a good drug to be given to patients who have come with a follow-up with predominant symptoms of breathlessness. If the ICS LABA is not working, then you may consider switching the inhaler device, or or investigate other causes of breathlessness, such as congestive heart failure is a very common comorbid condition that is associated with that. If the patient has predominant exacerbations, then think of giving inhaled corticosteroid as an add-on drug to the LABA plus LAMA. You may consider giving roflumilast if the patient has symptoms of chronic bronchitis or the FEV1 is less than 50%, and consider giving azithromycin if it's a former smoker because of recurrent lower respiratory tract infection. So that's the standard pharmacotherapy of COPD. Then the realization that you could reduce mortality in COPD, which was until very recently, ascribed only to long-term oxygen therapy, is the only treatment that can reduce mortality in COPD. But now, so many treatments can reduce mortality. Especially the use of triple drug combination is in the recent past has been shown to reduce mortality in COPD, and that's a very good sign because no pharmacotherapy was shown to reduce mortality earlier, but now there is good evidence to show that use of ICS plus LABA plus LAMA can reduce COPD mortality to a significant amount. Like asthma, the GINA guidelines have been focusing a lot on choosing the right inhaler device, ensuring that the adherence is proper, and so on. There's a big portion of the GINA 2023 report that talks about choice of inhaler device. Remember that a lot of these long-acting bronchodilators are available in a dry powder form, and many patients of COPD may not necessarily be able to generate the inspiratory flows to use the dry powder inhaler devices correctly. So there's a caution mentioned over here. Wherever possible, prefer to use an MDI with a spacer and so on. But a lot of emphasis on ensuring that the technique of using the inhaler is correct and the adherence is also proper. The non-pharmacological treatment has also also got a lot of importance, and especially self-management educational programs like what we used to normally do for asthma, maintenance of exercise program and physical activity, adequate sleep and a healthy diet. But more important than all this is the right-hand side of this slide that tells you which vaccines patients of COPD must be given. 5 vaccines that all patients of COPD must receive: influenza vaccine, pneumococcal vaccine, COVID-19 vaccine, the pertussis or the diphtheria pertussis tetanus vaccine, the herpes, the shingles vaccine. 5 vaccines should be given to all patients of COPD. There's a lot of emphasis on that. Pulmonary rehabilitation is also, there's a big section on pulmonary rehabilitation. So here are the interventions that reduce COPD mortality. And you can see that pharmacotherapy for the first time is now established as a treatment that reduces COPD mortality, which was not there before. And in the non-pharmacological treatment, it was only LTOT. Now, smoking cessation, pulmonary rehabilitation, non-invasive positive pressure ventilation, lung volume reduction surgeries have all been shown to reduce COPD mortality. Exciting times for COPD, where now we have good scientific evidence that we can reduce them from dying. There's a very new proposal about the classification of the acute exacerbation of COPD. Until recently, we were classifying acute exacerbation of COPD into mild, moderate, and severe. And that was largely based on the type of treatment that was required to treat it. So if the patient required only a SABA treatment, then we called it as mild exacerbation. If the patient required SABA plus antibiotics or an oral corticosteroid, we called it moderate. and if the patient required hospitalization, we called it severe. But this classification was retrospective after the treatment that the patient received. The Rome proposal was published in the American Journal of Respiratory Critical Care Medicine last year, and that is now included in the GOLD 2023 report, giving you very specific objective criteria to label the acute exacerbation of COPD as mild, moderate, or severe. And for this, various parameters are used, such as the breathlessness, the visual acuity scale, then the respiratory rate, the heart rate, the resting oxygen saturation, the CRP levels, and so on. So based on all these parameters, you should objectively categorize them into mild, moderate, or severe, and then you treat them accordingly. One of the other new things that has happened in the 2023 report is this very, very big section on surgical and other interventional therapies in patients with COPD, especially those with emphysema. So there's a lot of mention about bulectomies, a lot of mention about endoscopic lung volume reduction surgery, mention about endobronchial valves, lung volume reduction coils, and lung volume reduction surgeries. So I think these are exciting times for surgeons and to use this as an added form of treatment. And they also talk about the importance of lung transplant in patients who have severe COPD. So these are all the new changes that have taken place in the GOLD 2023 report. And I must say that this has been a very exciting time for COPD, because we have never had so many new changes come in one single report. This is all being written, and there's a manuscript that will be published in the Blue Journal, in the Lancet Respiratory Medicine, and the European Respiratory Journal very soon, summarizing some of these important changes that have taken place. So I think exciting times for COPD, and I hope that this presentation has given you enough knowledge and confidence to change your clinical practice for the betterment of the patients of COPD. Thank you very much.
Thank you very much, Dr. Sandeep Selvi, for the very detailed presentation on the GOLD guidelines. And Dr. Sandeep Selvi, actually, is a regular speaker in RESPIRE. So moving to the third lecture on the symposium, do casual use of steroids and antibiotics cause harm? So it's my pleasure to introduce Professor Tom Wilkinson. He's the Professor of Respiratory Medicine, Faculty of Medicine and Honorary Consultant, University Hospitals, Southampton. It's over to you, sir.
Hello, and very pleased to be with you presenting today. My name is Professor Tom Wilkinson. I'm from the University of Southampton in the UK, and I'm presenting on the topic of COPD, thinking about the role of microbial dysbiosis and the impact that treatments such as steroid therapy can have on that axis. It's a real pleasure to present at the Sri Lankan College meeting. I'm sorry I can't be with you in person, but I look forward to taking some questions after the presentation is delivered. So here are my conflicts of interest. I do work with industry to develop new drugs for patients with COPD.
Hello, Dr. Mohammed. This is Dr.
So, as I said, sorry I can't be with you in person. I remember Sri Lanka with great fondness. I was in the medical school in near Kandy in the early 90s.
I don't mind. Is the recording clear enough to you?
I had a wonderful time, and I'd very much like to return at some point.
I'll be in the background. If there's any problem, you can tell me. I can.
So COPD remains an important global challenge, and I know in the UK and in Sri Lanka it carries an enormous burden of disease for patients and for health systems alike.
Thank you so much.
Our current treatments for COPD are inadequate. They have very little effect on the long-term outcome of the disease. They have some effect on treatment, on treating symptoms, but actually have very little effect on prevention of exacerbations and other key events. Part of the issue is that we know not enough about the biology of the disease, and in particularly the interaction as shown here between the host response and the bacteria and viruses which commonly infect the airway. It's also true that some of our treatments may be actually worsening this interaction between the host and various pathogens. And really that's the focus of where we're going to think about today. So the current treatment paradigm, for example, for acute exacerbations of COPD is somewhat blunt. We require patients to recognize change in their sputum characteristics and almost to self-medicate with very little guidance about what to take and when to take it. We know as a consequence that treatment can be too frequent, patients taking antibiotics and oral corticosteroids too often, and there are side effects associated with that. And so understanding when is the right time to treat events, and indeed could we prevent these events from happening, is a really important target for research. For many years, the idea that the airway is not indeed sterile, but is colonized with a bacterial population has been well recognized. And there are now innumerable studies that have started to describe the nature of this colonization process. Indeed, my own work back in my PhD days in the early 2000s identified that not only were bacteria common in the airway, but higher numbers of bacteria were associated with poor outcome, particularly FEV1 decline in this study. So this is an important area, and since those early descriptive studies, the field of microbiome research has really exploded. The microbiome itself is a complex ecosystem of various different pathogens or bacteria, viruses, and indeed fungi that can coexist on any biological surface. Our whole body is covered with different bacterial colonies, and they play an important role in maintaining health, and if abnormal, can contribute to disease states. The human body is really quite dependent on a healthy microbiota, and I suppose we're most aware of that in its relationship to gut health. And now we are aware of things like probiotic interventions that can help preserve a diverse and healthy gut microbiome. In the lung, we understand less, but we do know that the microbiome of the lung plays an important role in maintaining lung health. It excludes key pathogens, such as invasive streptococci. It can help us develop and maintain our protective immunity. It actually provides a nutritive environment for the cells of the epithelium of the lung and can actually directly modulate inflammation. Really, the field has leapt forwards with the advanced nature of in-depth sequencing technologies, and the majority of studies we'll talk about today have used these to describe various different facets of the microbiome in the lung, so that we can describe the biomass, the number of bacteria in a biological sample, but also the diversity, how many different species of bacteria are present, understanding that a diverse ecosystem, such as microbiome, is often a picture of health. And we use 16S RNA sequencing to describe these features in the microbiome. And this is a technique that is now widely used in studies and is starting to drift into clinical practice as we understand its utility. Microbiome in the lung is not a stable situation. It's a dynamic environment where we're constantly inhaling new bacteria and they're dissipating throughout the lung. We're expelling bacteria as we cough and in mucus via the ciliary escalator, but also the environment of the lung changes, the nutritive state, the pH state, and the micro and metabolic niche alter, and therefore the different competing performance of different bacterial species leads to quite a dynamic process. The microbiota of the lung, therefore, tends to represent the environment of a particular individual or group of individuals. And we know that a healthy microbiome is very much characterized by a diverse pattern. And as we develop diseases, we can see fingerprints of those diseases if we analyze the microbiome. And probably that's most well understood in the context of cystic fibrosis. So what drives abnormalities in the microbiome and how what do they mean to us? Here I'd like to use an analogy that this healthy ecosystem of a field full of different wild plants and flowers can become quite disrupted if we constantly attack that ecosystem by mowing it in this example. Therefore, in the lung, this diverse ecosystem can actually become much less diverse and actually have a predominant type of bacterial growth if we treat it in the same way, either by using antibiotics or by stressing that environment with cigarette smoke or with inflammatory processes. And this is the scanning electron microscope with false color of the surface of a lung of a COPD patient where we've lost this diversity, and we can see overgrowth of Haemophilus influenzae in this context. So we've studied this in depth now, and what we've seen is that indeed, in the context of COPD, we see a loss of diversity and a shift in the pattern of the microbiome from one which is associated with health, rich in different bacterial taxa, such as Firmicutes, and we see an overgrowth in COPD of proteobacteria. These include species such as Haemophilus influenzae, which we know to be associated with poor outcome. And if we look at individual patients, we can see that individual patients indeed have their own fingerprint of a microbiome, which may associate very strongly with the nature of their condition and their outcomes. So each individual box here is a patient with multiple colors indicating diversity, as shown here on the left. You can see on the right here, pink is associated with Haemophilus influenzae, and there are some patients that have a microbiome which is entirely dominated by these important pathogens. And it's no surprise, perhaps, that these patients are the ones that have more frequent exacerbations and worse outcome. And if we try to type these patients and use things like CT scan to actually further phenotype their disease, we can see that patients with bronchiectasis as a part of their COPD, as shown here on the top line, compared to a general population of COPD patients without bronchiectasis, there's a much higher prevalence of this dysbiotic pattern of disease. Perhaps not surprising, but important to understand that within a condition like COPD, there's great heterogeneity, and the microbiota is different from one individual to another. So what are the relationships between the microbiome and different inflammatory profiles? Well, I think there is an important wealth of new data emerging. What we're aware of, that there are different phenotypes of inflammation in COPD. You can see patterns of neutrophilic inflammation and eosinophilic inflammation at its simplest description. In this work, which was a collaborative project between various UK centres, we demonstrated that actually the neutrophilic pattern of inflammation was associated with a certain pattern of microbial dysbiosis and the presence of Haemophilus influenzae, and that the key cytokines such as IL-1 beta, which is pathognomonic of the inflammatory processes in neutrophilic COPD, were much higher in this population of patients with neutrophilic proteobacter-dominated microbiota. So now we can understand that there are certain patients with COPD in which the microbiome and its abnormality is there hand in glove with a pattern of inflammation which may be associated with worse outcome and difficulty to treat. So what about treatment and the role of corticosteroids? So here, we're going to look at the interaction between inhaled corticosteroids and indeed oral corticosteroids, and this complex interaction between the host immune system and the microbiome. The interest in inhaled corticosteroids and infection and bacterial risk really rose from the early observational studies to show that high use of inhaled corticosteroids in COPD is associated with an increased risk of pneumonia, as shown in this review by Sami Suisa and Thorwak some years ago. And so it became a lot of interest to understand what was driving this association, and were there certain patients that were more vulnerable to this effect than others. In this review of meta-analysis of data by Mona Bafadil, she looked at the effect of corticosteroids at acute exacerbation as a treatment, and found that, again, there were different benefits of corticosteroids in different patient phenotypes, with patients with more eosinophilic inflammation more likely to respond and less likely to fail as a consequence of steroid use. And if we hark back to the previous slide, we can start to imagine that the microbiome is playing an important role in modulating this treatment effect. And let's look a little bit more at that. So if we look in ICS users, what is the pattern of microbial colonization? So this study, published in Lancet Microbe, looked at that. It looked at different patient groups, COPD patients versus healthy individuals and patients with and without COPD, and at different levels of bacterial complexity from the phylum down to the genera. If we look at the effect of inhaled corticosteroids, we see there are significant differences within the COPD population in patients that have used ICS and those that don't, with lower numbers of firmicutes, for example, which we felt were associated with a healthy status. So the long-term use of inhaled steroids may be creating an environmental niche which has an effect on the microbiome, and in turn, that effect on the microbiome may have a consequent effect on outcome. And we need to know that which patients are going to benefit from that interaction with inhaled steroids and which are not, so we can target those treatments more effectively. So let's look at another study. This is one of the very few interventional studies that has used a controlled study design to understand the effects of inhaled corticosteroids on the microbiome. This was by Alberto Papi and was published in the ERJ some years ago. He simply randomized a population of COPD patients to either salmeterol and fluticasone, the inhaled corticosteroid. And then he tracked their microbial colonization over a period of time, around 6 months, and looked at the impact of that treatment difference on the microbial colonization. And what he found was that in the steroid arm of the study, the microbial load, the number of bacteria, rose over that time, which is an important finding. And when he studied in which patients that load rose, he found it was the patients who had no evidence of eosinophilic inflammation. So this is a population of patients with more neutrophilic disease. So it appears that the paradigm that we're looking at and is now getting into the guidelines in clinical practice, that eosinophilic inflammation is a good indicator, whether it's a blood eosinophil count or sputum differential count, that you may respond advantageously to steroids, and neutrophilic inflammation less so, may be driven by an interaction with the microbiome, and that there may be additional factors that we can influence to improve outcomes further. So why is that? Why do inhaled steroids affect this niche, and what sort of cellular interactions are going on which can adversely or beneficially affect the nature of this interaction? So our group has been looking at the mucosal response to steroids for some time, and this is one paper published in the Blue Journal some time ago. This is looking at the role of mucosally associated invariant T cells. This is a particular niche cell which sits in the airway epithelium and plays an important role in recognizing pathogen load through a specific type of receptor engagement and coordinating the immune response. These cells would appear to be quite sensitive to the effect of inhaled steroids, and therefore we're dampening down the ability of the mucosal immune response to recognize bacterial growth and to influence its diversity and load. And in our population of patients that we studied with COPD on inhaled steroids and not, we found that there was a clear difference between the role of these mate cells and their number and function influenced by inhaled corticosteroid use. And in vitro, if we actually give steroids to these cells, we can completely damp down the response and interferon gamma response and their ability to kill, and indicating that at the doses we're giving steroids, we could be having a significant immune modulating effect. So what in summary does this look like, and what does it mean to us as clinicians? Really, we're now moving from an overall catch-all diagnosis and type of treatment for COPD to a more stratified approach. Here, we therefore can think about patients who have eosinophilic patterns of inflammation. They may have more firm acuities in their airway. They respond better to inhaled steroids and oral corticosteroids at exacerbation, and those treatments can be beneficial in reducing exacerbation frequency. There's a separate tranche of patients who have no picture of eosinophilic inflammation, but also don't yet have the strong neutrophilic inflammatory signal. They may have a balanced, more healthy microbiome, and it takes something like a virus to trigger off an exacerbation in that population. And then we have the neutrophilic population of patients who have rich loads of proteobacteria, particularly Haemophilus influenzae, frequent bacterial exacerbations, and the adverse effects of inhaled steroids are most strong in this population and perhaps should be avoided due to risk of pneumonia and worsening neutrophilic inflammation. So we have this fine balance in the lung that we have to maintain. And so when we're administering our inhaled steroid, we need to make really sure that we're maintaining the balance of inflammation and microbial growth and not creating an imbalance. So whenever we prescribe these drugs, which we do on a daily basis, we just need to consider which side of that balancing act they will lie on. Now, before I finish, I'd just like to talk a little bit about an interesting area of emerging research, and that's the gut-lung axis. We know that the microbial community of the gut is incredibly important to health, and we know there are vast numbers of bacteria in the gut. And we also know now that there's an interaction between this gut microbiome and indeed the lung microbiome. And that can be very beneficial to the health of our individuals. So things like diet can have an important effect on the lung health as well. However, there's also an impact of antibiotics. And I think just to highlight that we know very little about the long-term sequelae of antibiotic use. They tend to be used very frequently as exacerbation, but we need to just be aware of that. Studies are showing that antibiotic use can increase neutrophilic inflammation, increases the risk of bacterial overgrowth and loss of diversity. And once we get infrequent antibiotic use, growth of species such as Pseudomonas aeruginosa, we can start to see a pattern of decline, which is very hard to revert. So just to be aware of the potential impact of antibiotics when we're prescribing them, and more work is to follow in this area. The final point is that we are now starting to be able to understand this complex biology in the clinic. We can now take sputum and send that off for tests of microbial growth and diversity, antimicrobial resistance in near real time. And I think in the next few years, this area will expand enormously. So as clinicians, we can start to understand something about our patients' likely response to treatment by actually making these measurements and selecting the right patients for the right drugs. So finally, the key messages from this talk really were that the microbiome is a really important part of our lung health. Its diversity and balance, both in the gut and lung, are vital to maintain lung health and to reduce decline in lung function. Microbial dysbiosis in COPD is common. It's associated with a lack of diversity of bacteria. That lack of diversity is associated with inflammation, particularly neutrophilic inflammation, and poor outcomes such as lung function decline and exacerbations. That dysbiosis can be accentuated by an indiscriminate use of treatments, particularly inhaled steroids and possibly antibiotic use, and that there are further studies to be done to understand the relationships between these important parts of our lung health. Assessing the microbiome and indeed the clinical phenotype of patients is important before we treat patients with even simple drugs such as inhaled steroids and antibiotics. And we will learn much more as these tests are rolled out into the clinical setting, which will help us inform the best treatment for our patients. I'd like to thank you for your attention and thank the organisers for inviting me to speak.
I'd like to thank Professor Tom Wilkinson for shedding light on a neglected and developing area. For our final talk, we welcome Dr. Mohammed Munawwar, a consultant chest physician and interventional pulmonologist at the Lancashire Teaching Hospital in Preston, and he will talk to us about bronchoscopic interventions in COPD. Thank you.
Good morning. I'm Mohammed Munawar. I'm a consultant chest physician at Preston, Lancashire. It is an absolute pleasure to speak at the Sri Lanka College of Pulmonologists, and I'm most grateful for your very kind invitation. The topic given to me is bronchoscopic interventions in COPD. And this particular topic is of tremendous interest and has expanded progressively in the last few years. I'm going to cover this topic under the following headings. The larger section, which is interventional pulmonology in emphysema, and the second part, which is smaller and exciting for the future, which is interventional pulmonology in chronic bronchitis or COPD. As far as emphysema is concerned, it all started more than 20 years ago when a group of surgeons did a study called the NET trial. In short, what it showed is that where you have heterogeneous emphysema involving the upper lobes in particular, if you were to remove the upper lobes completely, you will see a dramatic improvement in exercise capacity and also quality of life. The problem, though, is the surgery is very risky, with a perioperative mortality of up to 10% and morbidity, inpatient hospital stay, and complications not insignificant at all. And this was a concern, and therefore work commenced on the back of this elegant NET trial to look at less invasive approaches to achieve the same result. And this group of workers, Tudor Thoma and colleagues from Royal Brompton in London, carried out a study with just 8 patients, and that made it to the Lancet. Such was the importance of this trial, which showed that if you block the entry to the lobes with one-way valves, that in itself led to an improvement in lung function and quality of life without the need for major surgery. This then led to a number of other evaluations. Primary among them, which is extensively investigated, is the use of valves. There are 2 types of valves which are available: Zephyr valves and the intrabronchial valves. These are what we call in the category of reversible procedures, because you can remove the valves and reverse the endobronchial lung volume reduction, as opposed to treatments which involve the bronchoscopic interventions in the lung parenchyma, which I'll touch upon briefly as well. As far as valves are concerned, the principle is as follows. You have, for instance, here, the right upper lobe, which is the most severely affected, with marked hyperinflation. You place a valve, and what happens is you get lung volume reduction. So you place 1 or 3 or 4 valves, and you block off the upper lobe, and that leads to a lung volume reduction. This is bronchoscopic lung volume reduction. An example is seen here. This is actually a Zephyr or pulmonix valve, which is also called a duckbill valve, which is opening and closing, opening during expiration to allow air to escape, whereas it's closed during inspiration, and thus it produces bronchoscopic lung volume reduction. Here is a real demonstration in a patient where the catheter with the valve and this measuring device, which you can see here, because there is a 4.0 valve, there's 5.5, there's something called a low profile valve, shorter, etc. So very carefully after measuring, you can deploy the valve. And this deployment results
the emphasis
in
Zephyr
a
endobronchial
one-way
valve is an
valve,
endobronchial.
as you can see here. Again, it's called the duckbill valve for this reason. Very effectively, it does not allow air to enter. The landmark study way back nearly 13 years ago was WEN trial. What it showed is that in principle, this would work and improve dyspnea and quality of life, but it was dependent on whether the fissure between the chosen lobe and the adjacent lobe was perfectly intact. Otherwise, if you were to block this lobe, if the fissure was not intact, then air can enter from the adjacent lobe, what is called collateral ventilation. So there was a need to check whether collateral ventilation is present or not in advance. How did we do that? We use a device called the Chartis balloon catheter, again made by Pulmonx. And when you use bronchoscopically introduce this catheter with the balloon and inflate the balloon in the chosen segment where you're hoping to place the valve, what happens if you measure the expiratory airflow, it would go down progressively and the airway resistance will go up. This indicates collateral ventilation negative, and therefore this patient will benefit almost certainly by the placement of valves, as opposed to this one, where the expiratory flow continues because of ventilation from the adjacent lobe, and the resistance is not going up, and therefore this is collateral ventilation or CV positive, which means that there's no point in placing a valve. This is not likely to benefit the patient. Now, that is an invasive assessment of collateral ventilation. You can, to a certain extent, get an idea with a non-invasive assistant, and a number of tools available called quantitative CT. One such organized by Pulmonx is the Stratix platform. This allows you to capture the CT scan, upload the CT scan, and then you get a very detailed report, including the fissure integrity, whether it's 80%, 90%, 95%, and so on. And when it's more than 95% fissure integrity, then you could get away without carrying out the invasive Chartis assessment. And when it's less than 85%, and this has been shown in trials, when it's less than 85%, it's almost certainly going to be collateral ventilation positive. That is, the fissure integrity is not there, and therefore you can plan your treatment based on this Stratix assessment. A number of studies have been carried out in this field with endobronchial lung volume reduction. The Chartis study, the Believer Hi-Fi study from London, the Stelvio study from Netherlands, IMPACT study, which was in homogeneous emphysema. For the first time in the back of the study, we came to know that even in homogeneous emphysema, if the fissures are intact, you can potentially treat with endobronchial valves. The bottom line with all the studies in the interest of time is that up to 6 months, we saw an FEV1 improvement, 6-minute walk test improvement, and quality of life dramatic improvement in these studies, carefully selected patients, and performance of bronchoscopic lung volume reduction. One further, more recent study called the Liberate trial, again confirmed this in a larger cohort and also showed that the response was retained up to 12 months with regard to lung function, exercise tolerance, dyspnea, and quality of life. Yet another valve is available besides the Pulmonx, which I've shown you. This is made by Olympus, called the spiration valve. Again, a beautifully designed valve, like an umbrella, as you can see here. Why is it important? Because, as I mentioned earlier, it's a reversible technique. So if there is any complication and if you need to remove the valve, you can very easily, during routine bronchoscopy under sedation, you can grab hold of the stem and remove this valve. Here is a demonstration of how the valve is being placed. So this is the spiration valve with the Olympus valve. And again, this has been studied. There are a few studies to show that this valve also is effective and it is safe, relatively. I say relatively, as I'll show you in this particular patient. This is a classical patient who presented with severe emphysema, heterogeneous, predominantly, and the most severely affected lobe was a right upper lobe, and lung function criteria were fulfilled. What do I mean by this? FEV1 more than 20% and less than 45%. Residual volume, very important. Hyperinflation is crucial when patient is selecting patients. More than 200%, more than 175% you can consider, but when it's more than 200%, all the more likely that these patients will respond to endobronchial lung volume reduction. 6-minute walk test more than 150 meters. And you can see here, that is the fissure. And after placement, you see the right upper lobe is completely collapsed. And you can see the valves here, very nicely positioned, and there is atelectasis. However, 24 hours later, see what happens. Very large tension pneumothorax. Something you need to be prepared for with these patients. A chest drain was placed hastily, replaced with a larger chest drain. Eventually, he recovered, and a few months later, when he was seen, he was a lot better. And you can see the FEV1 has nearly doubled, residual volume has gone down, and 6-minute walk test has improved as well dramatically. So that is about the reversible technique, the endobronchial valve, which is the most extensively used, quite rightly so, because it's had a business base. Biological lung volume reduction, in the second section where we're treating the lung parenchyma now, we're talking about, there are 3 techniques I very briefly mentioned. The technique which is not used so much now and still under evaluation after nearly 15 years is the use of a sealant called a hydrogel fibrin thrombin mixture, and causes inflammation and lung volume reduction in this fashion. But because of side effects, quite severe pneumonitis, it's not used at the moment. Some studies have been carried. Then the use of coils. You can see lung volume reduction using coils. This technique is demonstrated here. Essentially, the coils go in straight, and once you place it, this technique requires general anesthesia and fluoroscopy. You can see the catheter with the loaded coil. As you go in and place the coil, it goes in straight and then contracts and pulls the lung towards the hilum. Like this, a number of coils are placed, up to 10 to 12 coils in the lobe that you have chosen, and then you have to treat the other side after a few weeks, the contralateral side. This is right upper lobe lung volume reduction with coils, which is being demonstrated. So this coil placement can be quite expensive, and currently it's not available, although some newer coils are being evaluated and may be available in the future. The last technique in the section on irreversible bronchoscopic techniques for emphysema is the use of steam or water vapor. This is called bronchoscopic thermal vapor ablation. And this is used, heated water vapor is used and has been shown to be effective. And what do we do here? We again calculate very carefully with a software to see each of the lobes of the lung. This is generated based on the patient's HRCT, and it tells you which part of the lung is most severely affected. A number of measurements are carried out as shown here, and you can see here the largest amount of volume is in the right upper lobe apical segment, and therefore this may be a suitable one for treatment and has also been treated previously. Then once you've decided on the particular lobe, or more commonly now segment, because initially lobe itself was treated and that led to severe pneumonitis, and therefore based on a study which I'll show you in a minute, we now treat at a segmental or subsegmental level, and then there's the first sitting, and maybe if there is no problem, then you do a second sitting with another segment and so on. It calculates the treatment time. It generates a treatment plan from that software. And then once you're ready, you introduce the balloon through the bronchoscope into the chosen segment, inflate the balloon, and then fire the steam. It's just for a few seconds, the steam is fired. At the end of the procedure, once you've fired the steam, what do you see? You see a blanching effect, which we'll see in a minute. So this is the kind of blanching effect that you'll see at the end of the procedure. As far as the chest X-ray appearance is concerned, this is the patient who's been treated in the left upper lobe, and you can see post-procedure the amount of constriction and lung volume reduction which has taken place. This is segmental treatment. The reason for it being segmental treatment, as I explained to you earlier, is this trial called the STEP-UP trial, where patients were treated in a multi-center parallel group randomized fashion. And what it showed is those areas, those segments which are treated resulted in an improvement in FEV1, quality of life, and 6-minute walk test. So in short, for emphysema, what you have available definitely and extensively used is the use of endobronchial valves. And secondly, vapor, where in some centers, we use it in our center, but only within the umbrella of the research registry because it's not perfectly proven yet as far as its benefits versus risks is concerned. So you need to have an algorithmic approach to carefully select these patients in a multidisciplinary setting. The important criteria to remember is that FEV1 greater than 20% and less than 45%, DLCO greater than 20%, residual volume greater than 200%, and 6-minute walk test greater than 140 meters. And then you do the QCT, quantitative CT segmental analysis, which I've shown you. And then go through as a multidisciplinary team. Consider, first of all, whether the patient is suitable for surgical lung volume reduction, which has the best results. The next best results, or close second, would be use of valves, one-way valves, endobronchial valves. And if they don't fit into any of those categories, we may consider thermal vapor ablation. Otherwise, rest of it should be, and even thermal vapor ablation should be part of a clinical study. The second section is brief. I'll just do a very quick overview, just some headlines for you. There are 3 techniques which are available for treatment of patients with COPD, chronic bronchitis. This first one is a COPD treatment with radiofrequency energy by the use of what we call as targeted lung denervation, where a catheter is passed into, as you see in a minute, and a radiofrequency generator is used for ablation of the parasympathetic nerves. And this is very close to the main bronchus, as you can see, where the nerves are running. And this catheter is used to ablate. There's a thermoelectric plate to cool fluid, which you can see here. That's the radiofrequency generator. And you can see how the ablation is taking place. You turn it around, and then you ablate the other side as well. So this is the catheter which is used for this. This is targeted lung denervation, and this has been studied as well. There are a number of studies, the Airflow 1, Airflow 2, Airflow 3, and there's accumulating evidence now to suggest that this may be helpful in the future, so just watch this space. 2 other techniques, very briefly. One is the use of cryospray, essentially liquid nitrogen at minus 196 Celsius with a predetermined metered cryospray. And this is used to essentially what you're trying to do is to target the goblet cells in those patients with chronic bronchitis. And it seems to be well tolerated and improve symptoms and quality of life, but we'll have to wait and see as the trial results unfold. Final treatment that I want to mention, again, for chronic bronchitis and targeting goblet cells is the use of a pulsed electric field called rheoplasty. This system uses a basket, which I just showed you. And what it showed in one particular study is that rheoplasty results in reduction of mean goblet cell hyperplasia. And besides that, improvement in COPD assessment test and SGRQ. So this is called rheoplasty. And as I've shown you already, the use of a basket to the catheter to convey high frequency duration energy in a form of a pulsed electric field. So rheoplasty, again, something that is being evaluated. So in conclusion, bronchoscopic interventions in COPD, particularly emphysema, are exciting and evolving, but are unfortunately quite expensive. The evidence for endobronchial valves is established. There is some evidence coming through for the use of vapor. We need to see what happens with the new coils which are becoming available. Crucial is systematic assessment and patient selection in a multidisciplinary team setting. Emphysema MDTs have been set up certainly in the UK, throughout the UK. And what we found indirectly is that there is an increase in the number of lung volume reduction surgeries carried out compared to before. Cost is an issue without a doubt, and we need to be prepared also for complications because as we have got better and better at placing endobronchial valves, the pneumothorax incidence has gone up from single figures now to up to 40%. So you've got to be prepared to deal with a pneumothorax should it occur. Thank you very much indeed for your kind attention, and I'll be happy to take any questions during the discussion session.
Thank you very much, Dr. Mohammed Munawar, for the excellent presentation on interventional bronchoscopy. And now the symposium is open for any clarifications or any comments. And I think the international speakers have already joined.
May I ask Dr. Munawar, thank you very much for an excellent presentation. What are the procedures you'll use in patient selection? That seems to be the key part here in deriving a benefit from these very complex and expensive treatments, but as you say, those that are not without side effects and problems.
Okay, first thing, of course, is the patients with, I hope you can hear me.
Yep, we can hear you fine, thanks.
Okay, thank you. Thank you very much. Thank you very much for the kind attention and for the excellent question. The first thing we do is the patients with emphysema need to be symptomatic. They need to be symptomatic to benefit from the treatment. The second thing is, ideally, they should have stopped smoking for at least 6 months. Third is lung function criteria. They need to fulfill the lung function criteria, as I have shown you there. The most important criterion is with the body box, you need to have residual volume, ideally greater than 200%, but at least more than 175%. That's the first lung function criteria to look at. Next is FEV1, between 20 and 45%. We stretch it up to 50%. And the next bit is 6-minute walk test, having at least 140 meters, covering at least 140 meters. The next criterion is they should have completed pulmonary rehabilitation. And then we look at the HRCT, at least 200 slices with the HRCT. And if the HRCT confirms that there is no contraindications, such as nodules, bronchiectasis, pulmonary fibrosis, and so on, and the patients do not have recurrent infective exacerbations, then they would satisfy the criteria for a bronchoscopic intervention. Then you have to decide on what intervention, whether it's going to be surgery or it's going to be bronchoscopic intervention with valves, both of which are available, evidence-based, or something under the research arena. So that's sort of a systematic, step-by-step approach we need to take.
Thank you very much. Any other questions? Dr. Amita Fernando will ask a question.
Sandeep, my question is to you. Thank you for that excellent presentation. It's great seeing you. You have put on a little weight since I saw you last.
Thank you.
It's about COPD, and the contraindications you said about inhaled steroids. So in our part of the world, we see quite a lot of patients post-TB with COPD. What are your views and how would you approach these patients? Would inhaled steroid not be indicated in this patient?
Well, so a very, 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 very good question. We have recently just undertaken a big nationwide registry of patients who suffered from pulmonary tuberculosis. They had pulmonary tuberculosis, taken pharmacotherapy, declared as cured. The treatment is over. They come to a clinic with symptoms of cough and breathlessness. And in about 1,000 of such patients, we have done spirometry, both pre-bronchodilator as well as post-bronchodilator. And surprisingly, we find that more than 50% of these patients of post-TB lung disease show evidence of fixed airflow obstruction that we would label as COPD. So post-TB associated COPD seems to be a very common clinical manifestation, especially in our part of the world. Now, how should you treat them? As of now, there is no randomized controlled trial that has evaluated the right pharmacotherapy for this. Although gut feeling tells me that I would rather start with I'd rather start with dual bronchodilators to make sure that you have opened up the airways at least and the symptoms have reduced. But there are a lot of these patients who have previous history of asthma or a history of atopy, or what we call as asthma COPD overlap. Then you have no other choice but to give them an inhaled corticosteroid. Be very careful. I mean, keep a close watch for relapse or reactivation, because inhaled corticosteroids are known to cause relapse and reactivation. So as long as you're aware about it and keep a close watch, you may use inhaled corticosteroid. But as of now, there is no good scientific evidence to support that, which is the right treatment for these patients.
Amit, any comments? Okay. Thank you. We have another question from the front here.
Hello, Sandeep. This is Ashok Shah here.
Oh, Ashok, wonderful to see you there. Wow.
Well, TOPD is the elephant in the room as far as we are concerned. We all knew about it, but we never knew about it. In fact, now it's time to have a programmatic management of TOPD or whatever it's called. Because this is, as far as data is showing, this is a more severe form of the disease as compared to COPD also. It starts at a younger age, more hemoptysis, etc. And there is a thought that maybe fluticasone, it stays a longer time in the tissue. So if you have to use steroids, maybe it's budesonide that should be used. That's just what I wanted to add. What's your thought on that?
I agree with you, Ashok. I think it is the elephant in the room. We have been seeing it for all these years, but never gave it the due recognition that it deserves. And I think it's time, especially for countries like ours, India, Sri Lanka, and the neighboring countries, to start now looking for these patients and not denying them the appropriate pharmacotherapy that they would otherwise benefit with. So it's a very important phenotype of COPD that we should seriously start looking at, especially in our countries.
I think we should have a programmatic management of post-tuberculous lung disease. In fact, there's a demand for it. And in fact, there was a first meeting post-programmatic post-tuberculous lung disease meeting in South Africa in 2019.
Yes, absolutely. I mean, we should take a lead role in these, because these are more common in our part of the world. So we should take charge of that and find appropriate solutions and answers to a lot of these unanswered questions.
Miss seeing you in Pune last time. Anyway, good to see you
I'll
today.
see you, yes. Nice to see you.
Another question here from Dr. Kirti Gunasekara.
This is directed to Professor Tom Wilkinson. Yes, thank you very much for that thought-provoking lecture on the microbiome. In your slides, I noticed that even when you take across the spectrum of normal people, it varies so much. It varies so much, but the microbiome varies so much. How do you sort of take it at what point that this is going out of control and which is going to be very harmful? I know that you said that the Haemophilus is more predominant in some, and I also want to find out whether it differs in different parts of the world, this microbiome, when you look at the pattern, or is it a similar pattern that you find right across the globe?
Thanks very much. Those are great questions. I don't think we yet have the complete answers. So the microbiome is indeed quite heterogeneous. So it is also affected by how you study it. So if you collect sputum or use bowel or a protected specimen brush, you do get different data. And so it's very hard to compare sometimes one study with another. What we do know is that these are not absolute characterizations. So whilst there's a trend towards dysbiosis and a loss of diversity as you get more severe disease, you can in fact have COPD patients with quite normal microbiota. And so what we don't understand are the drivers to that. In larger population studies, there's clearly a dysbiotic picture associated with the condition. But if you take an individual patient, we don't yet have clinically useful cutoffs to help us understand whether an intervention would be worthwhile or not, for example. So there's a lot more work to be done in that. In terms of how it varies globally, There isn't, again, a lot of good comparative data, but there are studies from the North American cohorts, from Europe, from Asia, and actually the patterns are quite similar. So it doesn't seem to be that different at a significant population level in terms of the hundreds of patients in a typical cohort. But again, on a patient-to-patient basis, that's not been studied fully. I think, as I tried to get over my talk, this is still an exploratory field, and we need to now start to translate these findings, as you suggest, into data we can understand to drive clinical practice, but we've got a bit of work to do yet.
If I can add something to this?
Of course, Sandeep.
Yeah, so we did some study on microbiome in patients with COPD in Pune city here, and more or less we found very similar findings, Tom. So the proteobacter, those numbers seem to be suddenly go up. I think that's a worldwide observation.
Yeah.
But we also did look at pathogenic bacteria in the induced sputum of patients of COPD. And what we found was something very fascinating, that the numbers of H. influenza, Moraxella, Pseudomonas, and Streptococcus pneumoniae was significantly higher in patients of COPD, even when they had stable disease, no exacerbation. But the bacterial count that they had was very high, pathogenic bacteria. And we also then went on to look at the phagocytic activity of peripheral blood monocytes. We converted them into macrophages in vitro and then fed them with these pathogenic bacteria, and they were unable to phagocytose or eat them. So there is a greater number of pathogenic microbes and defect in the phagocytosis of these bacteria in patients of COPD. And so that's a very interesting thing, Tom. So this was also shown by the Imperial College team in smokers COPDs. They have a defect in the bacterial phagocytosis, and therefore the pathogenic bacterial load increases. And probably argues for the fact that do we need to give them, chronic antibiotics or a long-term antibiotics to reduce the load of pathogenic bacteria. But very, very interesting observation and very similar to what you found, Tom, in your studies.
Yeah, thanks, Sandeep. I think those mechanisms are common to many different patients. I think the niche in COPD is a complex one. So macrophage dysfunction, as you say, is probably very important. We've also shown a failure of distribution of immunoglobulins, particularly IgA, in the airway. And it's probably true of COPD, there are many different combinations of factors which have a slightly different role in an individual patient. We know it's such a heterogeneous condition. So eventually selecting, a bit like the previous talk, selecting the right patient for the right intervention will be key. I'm just not sure what those tools are yet, but it's a fascinating area. We'll have to chat about our data, Sandeep, for a future occasion.
Thank you very much. One last question.
Yes, my question is to Tom. Thank you for those insightful presentation and an exciting area. My question is also on Haemophilus. Is this Haemophilus typable strains or non-typable strains that you have isolated in your COPD cohorts? And does bronchiectasis and overlaps of bronchiectasis have any role to play? Because in our parts of the world, we see a significant overlap with bronchiectasis in our COPD cohorts. So does the vaccine have any role to play in these patients?
So thank you. So this is non-typal Haemophilus influenzae. So this is the non-encapsulated type. So the conventional Hib vaccines are not effective against these types of bacteria. However, there are new vaccines that are emerging for non-typal Haemophilus influenzae. I was involved in developing one, fortunately, was not positive in a phase 3 definitive study. So what we don't understand are the immune correlates protection against NTHI, non-typal Haemophilus. It may not be the same serologically driven immune response. So I think this is an important area for future research. And I think that in bronchiectasis, your second part of the question, in our London cohort where we did some of the initial work, bronchiectasis was not uncommon. It's not as common as in Sri Lanka or India. But there was about 25% of people who had some degree of CT diagnosed bronchiectasis. And they did have an accentuated dysbiosis, so they were more likely to have higher bacterial load more likely to have Haemophilus influenzae, and more likely to have this pattern of loss of diversity. So I think in your patients, that's certainly probably going to be an increased risk factor. And as we know with bronchiectasis, with overgrowth with other bacteria such as Pseudomonas aeruginosa, there is a clear role for bacterial dysbiosis in the etiology of exacerbations of disease. So I think that group really would be an important one to probably study further and perhaps think about intervention if frequent exacerbations are occurring, for example. But it's a good question, thank you.
Thank you. Last question.
Sorry for that. It's for Vatsala. It's regarding this THC that they speak of, or this cannabinol substance. Is it related to cannabis, and why do they sort of talk of this when they talk of vaping?
Yeah, so there are different, actually, what is contained in the vape juice varies quite a bit. And some of it contains this THC, that's a cannabis-related product. So the THC, cannabinoid, because of the variability of the constituents. So that is one of the, when you consider this severe form of reactions, E-valley, sometimes that was related in some reports, but not all of the cases were related to THC containing vapor juice. So some of the cases were related to some of the cases had used these products with THC, but there are patients who had severe forms E-valley, but that vape juice didn't contain any of those products, but just nicotine. So it's quite a variable thing. And of course, contamination and illegal products will increase the risk of the severe reactions.
Thank you. So we've had 4 excellent talks bringing us right up to date with what's happening in COPD. Before I go on to thank the individual speakers finally, I just want to share with the audience some COPD research that we are doing here in Sri Lanka. It is not all international. There is a contribution we can make here. There's a study funded by the George Institute for Global Health looking at beta blockers in COPD, the so-called PACE study where bisoprolol as a RCT, double-blind, placebo-controlled, is being used to test whether it will improve all-cause and particularly cardiac mortality. We all know that this is a big burden for our patients with COPD. It has been done in 26 centers in Australia, New Zealand, India, and Sri Lanka. In Sri Lanka, our 4 centers are headed by Dr. Amita Fernando, Dr. Dusanta Madagedara, Dr. Eshan Pereira, and Dr. Ravni Karunatilaka. I am the national coordinator and a member of the trial steering committee, and I want to tell you that of the 240 patients that have been recruited internationally, over 140 have come from Sri Lanka. And they're delighted with the quality of our data, and we are recruiting. So first, I want to tell you that if you are interested in COPD research, it is happening here as well as internationally. And more specifically, if you all have patients that you think would be suitable for this trial, please contact one of the site investigators or indeed me. So it just ends for me to thank our 4 speakers, Dr. Vatsala Gunasinghe, Dr. Sundeep Salvin, Prof. Tom Wilkinson, and Dr. Mohammed Munawar for 4 excellent talks. And we would like to thank them very much for taking the trouble to speak to us today. Chandana, will you share this certificate with?
Thank you, chairpersons and esteemed speakers. Now I cordially invite one of the chairpersons to present the token of appreciation to Dr. Vatsala Gunasinghe.